You're listening to Sit, Stay, Learn with Dr. Adrienne Wright, a veterinary podcast brought to you by Ardent Animal Health.
Regenerative medicine is one of the fastest growing fields with new papers published every single day. As a busy mama too, I am guilty of not taking the time to keep up with the research, and I think a lot of other veterinary professionals are in the same situation. My name is Dr. Adrienne Wright, and I am the site leader and VP of Science and Commercialization at Ardent Animal Health. Life can get busy and heavy, and after a long, hard day at work, you probably aren't choosing to unwind with 16 pages of dense scientific data. I mean, come on, who is? That's why I've created Sit, Stay, Learn, a short podcast where I do the heavy lifting for you, I read the papers, and then in 10 to 15 minutes, we sit, we discuss it, and I give you all the details you need to know to make it feel like you're staying up to date with the research. For a little background about me, I've been working in regenerative medicine for over a decade now, and I'm actually leading the company where I started as an entry-level lab tech many years ago. Since then, I've been passionate about regenerative medicine for animals and providing veterinarians and their staff with the tools and support that they need to be successful with it in practice. For our first episode, I wanted to talk about platelet-rich plasma. I found this paper because I had two different veterinarians email me and ask if PRP had antimicrobial properties. I honestly had never thought about it, but if it did, it would be another huge benefit since we already know it's most often being used in the joint. And it might also explain why we see so few, if any, issues with going into the joint with PRP. It would also make sense since PRP is such a game changer for wound healing. I just guess I had always considered the wound healing aspect of it and not necessarily the antimicrobial effect. But this paper I found from a group in Portugal explored the management of wounds in dogs using platelet-rich fibrin, or PRF. As a reminder, we do link the paper that we're discussing so you can read it for yourself if you're interested. PRF is actually part of the Ardent PRP system. It is the gel clot that forms after we centrifuge to concentrate the platelets and we've added solution G. For injection, we wait for the liquid to retract from the clot, but if you want the PRF, then you would actually use that clot. In this paper, they looked at 8 dogs between the ages of 7 months and 9 years old, all of various breeds. They had 5 females and 3 males. The downside is that this is a case study. So I do want to acknowledge that. So we really don't have controls. And I think that this is the biggest variance between the clinical world and the science world, because as a scientist, we're always going to argue that we want more controlled studies, but these take time and they take money. And I think many clinicians would say that these cases you're seeing in practice can't wait for these studies to be completed to offer these options to their owners and to their patients who maybe aren't able to recover from wounds, or maybe this is a last resort, or what have you. So in this series, I definitely want to do a mix of both case studies and controlled studies, because I do think that each serve a purpose and there is a need for both in this veterinary community. So to get back to the paper, we have 8 dogs and we have 8 wounds. The wounds included a dog bite, a sub-Q ruptured abscess, a traumatic chronic wound, an ulcerative lesion, 2 dehiscents from surgery, and a myiasis infection, and a laceration. The localization of the wounds varied, so 7 out of the 8 dogs were already on conventional medications during the PRF therapy, so mainly meloxicam and amoxicillin. The clots were applied directly into the wounds. In 3 cases, the dogs received 2 treatments in the first week and then a single treatment per week until that wound closed. But in the other 5 cases, the dog received 2 treatments the first 2 weeks and then a single treatment per week until they reached wound epithelialization. Wounds did not receive any topical antiseptics, antibiotics, or any topical drugs to promote wound healing during the course of this PRF therapy. All treatments were well tolerated. We had no allergies, rash, fever, or any other reactions reported in this study. All PRF treatments produced noteworthy granulation tissue formation, noted as highly friable, intense reddish material at the wound bed. No infection was observed in the area or in the wound bed. Necrotic tissue was not observed in any of the cases. Complete wound closure, so out of 7 wounds, occurred in a median of 31 days, but it varied from 13 days to 42 days with a reduction rate of 0.23 square centimeters per day. Wound contraction, re-epithelialization, and crust formation were seen in all of the 8 cases. Dry crust formation was seen in 7 cases, and only 1 case had serous crust observed after day 18. All wounds had a notorious centripetal wound healing from the periphery to the lesion. All wounds had very minor aesthetic scars. Skin contraction was recorded in larger injuries, and hair growth was achieved in all cases. 2 of the 8 wounds had recurrence. All others didn't have any recurrence in the follow-up period, which was 2 to 12 months. Overall, in all wounds, we had a consistent and significant contraction of the skin in the first initial 2-week period. And this is evident from the slope in the wound contraction curve that you can see in the paper. The initial surface area of the 8 wounds ranged from 0.41 to over 12 square centimeters. And the median for these 8 dogs was around 6 square centimeters. The progressive wound contraction percentage was calculated at around 31% at the end of the first week. It jumped up to around 63% at the end of the second week, with one of the wounds already having complete closure. After 2 weeks, we did have to remove a case. It was case 4. It did not proceed any further and was removed from the study. At the end of the 3rd week, median wound contraction was up to almost 80%, and then 95% at the end of the 4th week. So a significant positive correlation was found between the initial wound area and wound healing duration, as well as the number of PRF clots applied, which when you think about it, it really makes sense. Larger wounds are going to take longer to heal, and they're going to take more material. No significance was found between the healing time and the number of PRF clots applied. So it wasn't like if you applied more PRF, you were able to get the wound to close quicker. But a positive significant correlation was found between the total number of PRF clots applied and the score of wound condition or cleanliness. So that also inherently makes sense. If the wound is a worse condition or is less clean, then you would need more PRF clots to get it to heal. But overall, I think this case study demonstrates that PRF can trigger local healing processes. They saw the highest rate of healing in the first 2 weeks, as noted by the wound closure percentage. Larger wounds required more PRF and more time to heal, which again makes sense. But when you're looking at these from a cost perspective, I did find it interesting that the number of clinic visits for wound treatment and bandage change was reduced when using PRF compared to conventional therapies. So I think some owners are going to say, well, this PRP or this PRF, maybe it's a little more expensive up front, but in the long term, this is how you could sell this to your clients. Only 2 of the 7 completed cases relapsed, and those cases did have confirmed presence of neoplastic lesions, and they were probably there before the PRF therapy. So we had a chondrosarcoma and a dermal squamous cell carcinoma. But overall, I would say this study is quite impressive, and it reinforces what we already knew, and that is that PRF or PRP should be a tool in your toolbox for wounds. The PRF clot was able to act as a natural tissue filler. It promoted epithelialization and wound closure, and it did all of this without the need for other topical antimicrobials or antiseptics. PRF therapy reduced the need for surgical intervention, reduced clinic visits for bandage changes, and appears to be a promising alternative to conventional therapy, or could even be your go-to in cases where conventional wound therapy isn't helping. And that's all for today. What do you think of the wound healing potential for PRP? Do you think that PRP has antimicrobial effects? For the text version of this episode, you can head to our blog. If you have questions on this episode or a paper that you'd like for me to review, you can email me at adrienne@ardentanimalhealth.com. I hope you all have a wonderful week. See you next time.